Kim Kramer. She's doing her self-introduction because I was very absent in not putting together her introduction. But I'll let her go ahead and tell you about herself. Dr. Kim Kramer from Sloan Kettering.
Thank you very much. It's very easy for me to give a boring, very boring background. I'm 5th generation from New York. Nobody from my family ever left the Bronx for 5 generations. And I am born and raised and trained all in New York, City University of New York, State University of New York, a little bit of time in upstate New York, which most people in New York City do not even consider to be New York. And I just got my 30-year pin from Sloan Kettering, but my biggest disclosure is on behalf of my team. We feel that taking care of you and your children is a sincere joy and a true privilege. So thank you, Pat, for inviting us to participate and to share just some of the things that we offer for children with neuroblastoma. So a few disclosures that outline some of the financial partnerships that MSK, some of my colleagues, and myself as consultants to YMABS have to disclose. Our major goals are twofold: to cure every patient with neuroblastoma, and that includes challenging situations, of course, patients with new diagnoses, but those that do not respond to what's considered standard of care, or those patients who have the disease come back after standard of care. And the other major goal, expecting that all of these children can be cured, the other major goal is to avoid side effects, and that comes by reducing exposure to conventional treatments, decreasing or not giving chemotherapy at all, or lowering the doses of radiation therapy. So this stems from the knowledge of many people here that have spoken yesterday and today that there are striking contrasts in the prognosis and therapy. So it really is incumbent upon us to know who needs more therapy, such as the patients in the bottom for high-risk stage 4, who needs less therapy or maybe just surgery alone, or who needs absolutely no therapy at all. We had this approach to either not giving therapy or stopping therapy back in the 90s, and that was for patients that had non-stage 4 disease without that MYC amplified gene. So N0 were newly diagnosed patients that were never exposed to treatments, and STOP patients that were referred to us, and we thought it was safe to actually stop. And those N0 and N-STOP publications are listed here. So this no therapy plan does exist for patients even with stage 3 disease. And they're patients that have had incomplete or no resection, again, with the idea of avoiding injury to wherever the tumor may be. And that includes no therapy for patients that have favorable molecular findings. So our young babies that have stage 4 without MYC-N have an extremely high cure rate. We do not have any open formal studies at MSK for these patients, but that is because the low-dose COG and PSYOP chemo treatment is so successful. The bigger question is, how many cycles can you give, and can you avoid potential long-term toxicity? Can we limit the number of subsequent cycles of treatment, even in the setting of an MIBG scan, which still may be positive? And can we avoid no radiation therapy, no antibody therapy, and no surgery? Here's an example of a patient with infant stage 4 On the left, you see that every dark area is really neuroblastoma in the bones and the bone marrow. And then after low-dose chemotherapy treatment on the right, all of those dark areas have resolved. And just for parents who may not have seen MIBG scans, there'll always be uptake in the salivary glands on the sides and in the bladder. But as you see, it's remarkable how even just a little bit of chemotherapy can result in a clean MIBG scan. We've also expanded the definition of these babies with 4S that may have skeletal metastasis, and showing here that observation alone, these babies are still cured. So we know that in high-risk situations, neuroblastoma is chemosensitive, and it is responsive to drugs based on the dose intensity. So here again on the left is an MIBG scan of a patient that had neuroblastoma throughout all of the bones, and after 5 cycles, there's a clean MIBG scan, pretty much showing resolution of most of the areas of disease. So we know that we're dealing with a disease that really is chemosensitive. Now, to decrease the long-term side effects that we know many of these children have, we've recently started a pilot called N9. My colleague, Dr. Kushner, is the principal investigator. And the goal here is to see whether you can achieve the same cure, the same response rate with 4 cycles of chemotherapy. And the key thing to note here is that these 4 cycles have no cisplatin, which we know damages hearing, damages kidneys, and 1 cycle of a regimen containing doxorubicin, which we know has long-term effects on the heart. So this is an ongoing trial, 4 cycles. Stem cells are collected in the event that they may ever be needed. Radiation therapy is given, and then there's consolidation with the anti-GD2 antibody naxitamab and the bivalent vaccine, and I can go into more details on that. But the key thing here is that we are hoping that this trial addresses the drawbacks of our previous high-risk trial or the COG induction regimens. So the goal to decrease the ototoxicity, to reduce the cardiotoxicity, and to have flexibility in introducing immunotherapy. The lessons learned over the years from prior treatment for high-risk neuroblastoma are definite long-term effects to all of these organs that are listed here. Definitely ototoxicity, a risk of having a secondary cancer. We have an ongoing trial to decrease the amount of conventional radiation therapy that is given. That's led by our radiation oncologist, Dr. Walden, and using proton beam. And then we have the studies that have incorporated long-term anti-GD2 therapy. So we absolutely need people that specialize in survivorship and people that are specialized in taking care of our very young patients who we expect to grow up and move on with their lives. And the key focus for many of our survivorship specialists are to address long-term pulmonary toxicity, to really understand what are the secondary malignancies that are either malignant or the benign tumors that can affect our patients. For example, there's something in the bone that's called an osteochondroma. There's something in the liver we see on scans that's focal nodular hyperplasia. Neither of these are really cancers per se, but our survivorship is really trying to understand how often they affect our patients. And another goal is obviously to reduce the radiation-induced secondary neoplasms. So, immunotherapy regimens that target the GD2, which is on the surface of neuroblastoma cells, are many. For years, we used murine 3F8 that targets GD2, and then there was a switch to a humanized form that's called naxitamab, and you've heard plenty about the chimeric 1418 dinutuximab. Basically, these are all fantastic drugs that are going to target what we want, GD2. They tend to differ in the dosing or the schedule or the hospital stay or what kind of immune adjuvant is used to boost them, but they're all fantastic ways to target GD2. Here's an example of a response of neuroblastoma in the marrow with humanized 3F8. The two left panels show the dark spots, which are where the neuroblastoma was involved before, and then an MIBG scan showing resolution of the neuroblastoma after the naxitamab and GM-CSF. Now, this comes up a lot. There are many ways to consolidate patients, meaning to try to remove every single residual form of microscopic disease that could still be there after an induction chemotherapy. Years ago, high-dose chemotherapy with your own stem cells given back was a major feature of our program. And the publications with the results for high-risk neuroblastoma treated with chemotherapy and transplant are listed here. But over the years, we did not appreciate an improved survival if patients had upfront chemotherapy and consolidation with the anti-GD2 antibody. So transplant for us was really stopped in 2003, and over the years, the published reports included 170 patients with stage 4 disease that were treated with chemotherapy and antibody and not transplant. And this number of patients allowed for a robust multivariate statistical analysis. Recently, the team from Barcelona, without transplant, reported similar results. So this similar event-free survival and identical long-term survival for stage 4 patients and patients with localized MYC and amplified disease are included in the publications here. So moving on to vaccine, there's a way to construct a drug that can target GD2 and GD3 that's highly expressed in neuroblastoma. So this was constructed in the Chung lab, and the vaccine is typically given with other drugs that boost the immune system. So, you know, if you or I get a vaccine for whatever virus is out there, you have to hope that your immune system responds and recognizes it and makes antibodies that will protect you against whatever it is you're being vaccinated. Well, it's the same type of thing here. So this is our schema for patients that get the vaccine in first or second remission. It's basically 7 injections of the vaccine over 1 year, and it's given with the immune stimulant beta-glucan, which can be taken orally and stimulates the immune system. And the goal here is to achieve prolonged anti-neuroblastoma immunity by inducing patients to maintain their own anti-neuroblastoma antibodies over months to years. Dr. Irene Chung published the results of the progression-free survival and the overall survival for 102 patients treated in greater than second remission. So about a third of these patients had had multiple relapses with a 6-year progression-free survival of 32% and overall survival of 71%. The current vaccine trial at MSK is a randomization of getting the vaccine and the glucan and plus or minus the GM-CSF. And the goal here is to understand, do we need those additional shots? Is the GM-CSF that important? Does it really improve things, or can it be the vaccine and the glucan alone? It also includes boosters in year 2 and at the end of year 3. So these are the challenging situations, patients that have an incomplete response to induction and patients that have the disease come back. But we really tackle these thinking patients can still be cured even in these challenging situations. And obviously, favorable prognostic impact by close monitoring, finding things earlier and then trying to address them early on. I've listed some of the non-myeloablative treatment options. Many of these you've heard about, combination chemotherapy with or without antibody. Several different regimens are extremely effective, even in the setting of prior exposure to some of these drugs. So they list high-dose regimens that we have the published results, as well as low-dose or oral medications. So all non-myeloablative treatment options that exist. Another thing that we instituted back in 2014 is the impact testing. So it stands for Integrated Mutation Profiling of Actionable Cancer Targets, basically looking at the genes and seeing, is there a gene there that a drug can target? So we test every tumor. It is sequenced for 468 gene panel, and we have a specialty team that weekly reviews all the data on all these patients. And it may be that patients can receive additional therapy based on the impact testing, or patients can be tested to see whether there happens to be the rare familial risk. The other genomic platforms that are also in use, and you've heard about these, but they really test similarly: Foundation 1, Foundation ACT, the MSK Archer panel, and the COG MCI, which you heard about earlier this morning. So innovations in the use of MIBG therapy, very commonly used for neuroblastoma that's refractory or relapsed. We administer it in a regular room. Patients are typically inpatient for 2 to 3 days. Our radiation safety team monitors, and hopefully patients have a great response. Stem cells may be needed, particularly if it's MIBG plus chemotherapy that is used. So my colleague Ellen Basu and Nita Pandit have devised 2 other ways of using systemic radiotherapy that are very much like MIBG. That is targeting the somatostatin receptors, Lutathera. You see on the left a patient that has extensive disease, and then on the right, after 1 injection of the lutetium dotatate, significant resolution of disease. There's also an ongoing trial using the drug copper sartate, which opened in 2020. Now, are there better ways to detect the disease as well as to treat? So MIBG scans, everybody here is familiar with, but we've had the first in human trial of MFBG, and this shows MIBG on the left and an MFBG scan on the right. The advantage to this scan is that no iodine drops are needed, since it doesn't go to the thyroid gland. You can get same-day imaging, unlike the typical MIBG scan 24 hours later. It used to be 48 hours later. And there's a higher picture quality. So it may be that a better way of detecting could also play a significant part in the treatment of these patients. So on to CNS disease. The most important thing that I could mention here is that most of you will never have to concern yourself with treatments that are needed, but we still have in our hands, it's approximately 10% of patients will have a relapse in the brain. This tends to occur early. It's not something years later that you have to worry about. It's usually right within 1 year or 1.5 years after the initial diagnosis. And it probably is because the brain, as we know from other pediatric cancers, is a sanctuary site. Cells can hide there, and you wouldn't know they're there until they start to grow. So we routinely screen patients for brain disease, mostly because there is a chance that a tumor in the brain can cause life-threatening issues with pressure or with bleeding. And so catching them early and addressing them earlier can hopefully avoid some of those life-threatening issues. The common symptoms are headaches, nausea or vomiting, sometimes changes in vision, sometimes the right side of the body works better than the left, a focal deficit, and occasionally seizures. In the past, it was very difficult to cure, but I'd like to walk you through some treatment options. So can the CNS sanctuary site be addressed? We do ask our neurosurgeons to resect a tumor if it looks like it can safely be removed. And the advantage of this is it will no longer cause a life-threatening issue with hemorrhage or pressure, but also the mutation status of the tumor may be assessed, and maybe now in 2023 there are some better targeted agents that can be used. We have also used combination chemotherapy. There are several drugs that penetrate into the brain better than others. Radiation therapy to the brain and spinal cord is still extremely helpful, as it is for many children with other kinds of brain tumors. Since 2003, we've been using a form of radioimmune therapy with the antibody that's linked to a radioisotope delivered into the spinal fluid, with the aim there of eradicating micrometastasis. So our target here is something called B7H3, which is on just about every pediatric tumor and most adult carcinomas as well. And this antibody can be labeled with a radioisotope to deliver a focal form of radiation. So the antibody omburtamab was developed in the Chung lab and licensed to Y-mAbs. It targets B7H3, which is overexpressed in neuroblastoma. We know that the tumors uptake the radio-labeled antibody, which could be labeled with 124 for imaging or 131 for therapy. When we give these medications, it is typically into a catheter, into the spinal fluid, but the patients are awake at the bedside and receive a test dosimetry dose, which tells you how much radiation is being delivered, and then a week later, a treatment dose. So we presented these at PSYOP last year, 107 patients at MSK treated with the radio-labeled omburtamab, and the survival here, and that is compared to our own internal historical controls that received non-omburtamab related therapy, the 19 patients in the purple. Y-mAbs has also conducted a multi-center trial treating 50 patients with CNS neuroblastoma throughout the United States and Europe. And then at MSK, we've treated 181 patients, including the 107 with CNS neuroblastoma, and then the remaining 72 patients that had B7H3 positive other kinds of brain tumors. In addition, the Pediatric Brain Tumor Consortium, which is 14 centers in the US and Canada, are undergoing a trial using this drug for patients with relapsed medulloblastoma and ependymoma. Now, the decision to approve the drug or not was based on the FDA's review, and they requested what Dr. Brown was referring to earlier, a randomized control trial, which would mean half the patients get the omburtamab and half would get placebo. So the decision to put resources and time into a randomized control trial is really between YMABs and negotiations with the FDA. But it may be that there are better drugs than the I-131 omburtamab, maybe a different isotope, perhaps a different antibody, but that is unclear. Nonetheless, for 2023 right now, we do recommend that the conventional treatments are considered in the event of CNS disease. So that's resection of the disease by our neurosurgeons when possible, the combination chemotherapy that we know crosses the blood-brain barrier, the radiation therapy to the brain and the spinal cord, and then there are several other drugs that also can be effective, oral temozolomide, and for the patients that are ALK positive, lorlatinib, and of course, if we are able to proceed with the intraventricular omburtamab, we would try to incorporate that. Okay, acknowledgements from the many people on my team. Naikang Chung has developed most of the drugs that I've talked to you about today, and my colleague Brian Kushner has published just about all of the references that I've listed, and he's also shared many of his slides with me. Dr. Modak is the service chief, and then the incredible other colleagues, nurse practitioners, our surgeons, neurosurgeons, pathologists, radiologists, radiation safety officers, our research assistants, social work, and survivorship team. If I can just put some faces to the names, this is Dr. Chung and his lab, who are still working on another generation of drugs that will help, and I'm sure Pat can invite him to speak about those in the future. These are my colleagues in nuclear medicine. Dr. Jason Lewis runs the whole program, but you know, the person on his right, Jing, for 20 years has been coming in at 4 a.m. in the morning to start the labeling process so that our young patients who need anesthesia for their scan later can actually get the drug earlier rather than later. So they are all entirely dedicated to, you know, making things better for our patients. And of course, some of you may know our nurse practitioners, Ursula and Maria Donzelli, two of my heroes in life. And this is our nuclear medicine team, Nita, who's up on the upper right, starting the MFBG protocol, and certainly involved with the MIBG therapy and copper sartate. And the most important, our inspiration. This is one of the first young little girls that I ever met years ago with neuroblastoma. Her mother is on the right, and like Pat, I don't know how she continues to, you know, run with the torch for decades and trying to improve things years after her daughter has passed away. And those are my parents over there who I try to take to every event with me. So they know Katie's family very well also. I've listed so many of the foundations which have supported our work, and you know, the support comes not just through philanthropy, it comes through patient education, awareness, advocacy, and most importantly, emotional support for our team. It helps more than you can ever imagine. And then with permission from the Band of Parents, I am plugging the Band of Parents, an amazing group of people dedicated to bringing better therapies for right now, not 10 years from now. And some of the things I've mentioned have only been given because the Band of Parents developed the resources. So if you are in the New York area, in the Bronx, September 8th, you don't have to even be you don't have to be a golfer. There's plenty of socializing, and it's all with the band's intention of bringing new and better therapies on board. Okay, my favorite quote, I don't know if any of you have seen that movie, Oppenheimer, 3 gripping hours, but there was a nuclear physicist who back during World War II had this line to say, and it's really wonderful, expecting that every child will be cured of neuroblastoma. His quote, "It is difficult to say what is impossible, for the dream of yesterday is the hope of today and the reality of tomorrow." And we really believe that. So thank you for the extreme honor to join you here, Pat, and
Thank you for
families.
coming.
Thank you.
Dr. Kramer. Is that Katie Hoke Foundation?
Yes.
Oh, yes, I know them very well, very well. Does anyone have any questions for Dr. Kramer? Okay.
What are, if any, are the preliminary results you're seeing with the MFBG? And if you have a patient who shows maybe lesions on an MFBG but not the MIBG, are you immediately treating them or just rescanning?
Yeah, no, so fantastic question. It's kind of in years past, if an MIBG was negative, but you had a strong suspicion that it happened to be the 5 to 10% or so that are not MIBG avidemia, we would try to do a PET scan. The PET scan is not specific for neuroblastoma. This is specific for neuroblastoma. So Dr. Modak at the last ANR meeting presented the data on the sensitivity with MFBG. I think there were about 30 patients that had both scans. MFBG is definitely more sensitive. You can get the results that day. You don't have to worry about those SSKI drops, which are bitter. Nobody, should have to take anything more. So it probably is going to be, a better modality, which can really help address things earlier and hopefully more successfully. Thanks for the question.
Okay. Go ahead.
With that scan, still on the topic, if a kid is MIBG non-avid, would they react to the new scan?
So that's what the trial is designed to assess. It does look like probably yes.
Okay.
Standard of care is to go with a PET scan if you see that the MIBG it happens to be negative.
But have they had children who are non-avid use the new
Yes.
scan? Yes.
Yeah.
Okay.
Yeah.
Okay.
Thank you.
Oh, one more question.
Sure.
For the vaccine,
Yeah.
children that have had the vaccine or started the vaccine, relapsed, and started again, have you seen, I don't know, like results where it's better, worse, or I don't know.
So can they get the vaccine again even if they've
well,
had
yeah,
the vaccine?
I know they can, but
Yeah.
what about the results of it? Is it improved or
Second time exposure. So I'm sure my colleague, Brian Kushner, is probably home writing that up right now if I were to guess. So, but it's a great question.
Okay.
But definitely, offering it as a possibility in the event of a second or subsequent relapse is definitely something that
I was just wondering if
typically
it
do.
was better
Yes.
and why, why, I didn't know, because, the antibodies sit there, but if they've had treatment to treat a relapse, like if they've had chemo, would it kill what they've already had before? I don't know. Does that make sense? I don't know
Yeah.
if that question makes sense.
No, it's definitely something to learn
Okay.
more about
Okay.
in that particular setting.
Okay, thank you.
You had a question back there?
Just a quick question and curiosity, and I apologize if I missed this. You talked about the omburtamab
Yeah.
within the setting of patients who had a CNS relapse.
Yes.
And again, I apologize if I've missed this, but has omburtamab ever been looked at for other patients?
Right. So out of the 181 patients at our center that have had the radiolabeled omburtamab into the ventricle, the 107 have had neuroblastoma, and the others are for other B7H3 positive tumors. So those are for babies as young as 6 months, and then for a couple of adult patients in their 70s that had brain melanoma, but the B7H3 was there. So we've tried it, but those numbers for each specific diagnosis are much smaller than the number of patients with neuroblastoma.
Okay, got it. And so you said there were 107 neuroblastoma patients
Yes.
who got omburtamab. And I guess were all 107 of those CNS patients?
Yes, those
They were.
are specifically patients that had documented CNS disease.
Okay.
Yes.
And so just a curiosity then, would we ever look at omburtamab for other patients who are B7H3 positive but maybe don't have something in their cranium?
Yes, and that's part of the PBTC study, is to
Okay.
look at it with other diagnoses as
Gotcha.
well.
Thank you.
So, my colleague, Dr. Modak, also has a trial delivering the radiolabeled antibody into the abdomen, into the peritoneum, for teenagers that get this rare sarcoma in the abdomen, and then and our neurosurgeon has delivered this radiolabeled drug directly into the brainstem for certain kinds of challenging gliomas. So there may be other indications, but again, moving forward with the antibody will be YMAB's decision. Thank you.
Okay, one more question?
Hi. So a question with vaccine, right? We have maintenance therapy, as like DFMO is a maintenance therapy. Many parents look to it as something to continue to do after standard of care, frontline, relapse, things like that are finished. But with these novel therapies of CAR T, like the gamma, oh my gosh, beta, whatever, coming to the forefront specifically for refractory relapse, kids that are struggling to get back to that NED status kind of thing. And obviously like CAR T is, the hope is, that those CAR T cells are going to keep working, kind of like the vaccine. So is there a place in the line of therapy for vaccine to still be used after something like a CAR T trial, or is the CAR T trial almost like another, maintenance therapy like vaccine would be, or where would how do those correlate with each other, I guess, in using side by side or one or the other type?
Right, so it's a super question. We have never compared, say, the vaccine as consolidation after chemo and antibody versus CAR T cells. But I'm sure there are going to be instances where we feel like everything has to be included, every treatment modality that could possibly address the refractory disease should be included. And if that's CAR T cells, that will be wonderful. So whatever way to get rid of the sanctuary cells or the cells that are refractory to the conventionals, whether it's CAR T cells plus vaccine, I think, we would fully embrace. Thank you.
Okay, is that it? Thank you, Dr. Kramer. Okay, we'll go ahead and break for lunch now. So at about 1:35, be back here if you can.